Welcome, hello. I'm Jamie Griffo. I'm the program director for the NYU Fertility Center, and I'm here to talk today about a rational approach to IVF according to the published literature. The field of IVF is an evolving field, and it's a mature field, and we've been practicing for many years since the first birth in 1978. The technology in its early days and even currently has problems. And the problems need to be solved, and we now have technology to solve them. And I'm going to review the literature today to see how we can do this and practice our field in a safer, better way. The biggest problem with in vitro fertilization has always been multiple gestation. And because of multiple gestation, twins, triplets, and beyond, a lot of the morbidities from IVF are associated with the preterm deliveries and the problems that babies encounter having gestated with multiple pregnancy. We need to solve this problem, and we currently have the technology. In the early days of IVF, we didn't, and we had to sacrifice pregnancy rates to limit multiples. We no longer have to do that. Miscarriage is another problem. Most miscarriages are caused by chromosomally abnormal embryos, and by screening embryos, we're able to solve this problem to some great extent. Another problem is ectopic pregnancy. A pregnancy in the fallopian tube as a result of IVF is devastating. When you spend all the time, energy, and money doing IVF to get a pregnancy and then have that outcome, it's not what we should be doing, and there's ways to reduce that risk. The hyperstimulation that occurs from the medications that we use for in vitro fertilization is now preventable, and there are techniques to avoid some of those complications without compromising pregnancy rates. Cost is an issue, and it always has been, and the good news is costs haven't kept pace with inflation. This was a very expensive technology and always will be, but there are cost efficiencies that have been developed. And then finally, medical risks, as all procedures have medical risks, and we need to keep our rewards way ahead of the risks. Why does IVF fail? Because that's the worst risk of IVF and the worst outcome. A patient goes through weeks of stimulation and surgical recovery of the eggs only to have the cycle fail. And clearly the biggest factor in that is age. And it's not male age, it's female age. Female age is the single most predictor of IVF success. Currently the trend is for women to delay childbearing, and because of that, it's more difficult to get them pregnant, and it's also the reason we're doing more and more in vitro fertilization. And now 2% of the babies in the United States are born through in vitro fertilization, and it has to do with these social trends. And really, it boils down to the embryo and the egg that it came from, because most of the problem is in the egg. An egg that sits in the early stages of meiosis from the time a woman is a fetus in her mother's womb and waits for ovulation and fertilization to complete meiosis with the chromosomal errors that occur, results in embryos that are chromosomally abnormal that look good under a microscope and look good in an IVF lab. And when we transfer those embryos and the patient doesn't get pregnant, or the patient miscarries or has a baby with Down syndrome, those are the outcomes we need to avoid. There's a lot to be learned about sperm, and clearly after fertilization, sperm appear not to have much of an impact, but there probably are instances where things can be improved in that arena, and there's a lot of research in that area. And this notion of idiopathic infertility, unexplained infertility, most of our patients experience it, and most of it is just an age-related decline in fertility as it relates to eggs. Since we first started in this field, we've known for years that younger women had a lower risk for having a baby with Down syndrome. The risk at 25 is 1 in 1,250 pregnancies, whereas at age 40, that risk is 1%. This slide, which this data was collected in the 70s, 60s, 70s, and 80s, tells us really why we struggle in IVF, because as our patient population gets older, this slide tells us that more of the embryos that we encounter are chromosomally abnormal. This slide is looking at one chromosome, the age-related change in chromosomal abnormality, and it's looking at one chromosome. We have 22 autosomes in X and Y, 23 pairs of chromosomes that all can be affected and impacted by the meiosis. And that's really what contributes to IVF failure, miscarriage, and bad outcome. If you use IVF success rates as an assay for the age-related decline in fertility and ask the question, what % of cycles result in a baby at different female age, And this slide is our data at NYU Fertility Center for about 10 years. And it shows the progressive decline. And what you see is that age 30, the pregnancy rate of around 60% is cut in half at age 40 to 27%, despite the fact that we're putting back more embryos and we're getting half the success, is an indicator of the age-related decline in fertility. And the fact that, when you use egg donation in a woman of any age and you get a 60% baby rate, it suggests that the root of the problem is the egg, and clearly that's the case, and the literature review that I'm going to do today will make that clear. So we've always been interested in chromosomal abnormalities in embryos, and in the early days I spent a lot of time looking at why patients miscarried from IVF, and we learned that most of the miscarriages that happen are due to chromosomally abnormal embryos, and the thought has always been if you could screen those embryos out ahead of embryo transfer, you could improve outcomes. And in addition, it's a tragedy when a 40-year-old patient ends up with a miscarriage and loses 3 more months of precious time at a time when fertility is changing. So our technology needs to address this, and it does. And in this study that we did looking at miscarriage material from assisted reproduction, we also showed an important fact that when we were doing day 3 embryo transfers, more of the miscarriages were chromosomally abnormal than the day 5 embryo transfers, which suggested a thesis that was dreamed up a long time ago but had never really been proven, in that if you culture the embryo longer, that you can select and do what we call Darwin in the lab, where there's this natural selection that the chromosomally abnormal embryos don't make it to blastocysts and aren't transferred, and you could get better outcomes. And indeed, the early studies with blastocysts showed that we had better implantation rates and pregnancy rates, and it was by that fact alone. So there was kind of a chromosomal screening going on in the culture in an indirect way, and this paper demonstrated that. We spent a lot of time trying to perfect the technique of blastocyst culture. Bill Schoolcraft and David Gardner were pioneers in this area, improving that technology. And our program currently is a complete blastocyst program. We don't do day 3 transfers anymore. And I think if you look at the trend in all the programs, many of us are trending towards blastocysts as the optimal method. And in this paper, what we did was we categorized how we changed from a day 3 embryo transfer program to a day 5 embryo transfer program. And the impetus for that was the 15% triplet rate that we were seeing in the 90s, when we couldn't select embryos that well, and we were putting back 3 embryos in many patients, and 70% of the patients weren't getting pregnant, but of the 30% who got pregnant, 15% had triplets, and triplets have bad outcomes. They have a multifold increased risk of cerebral palsy compared to singletons. They preterm deliveries and lots of problems. It's not a success of IVF to make a triplet pregnancy. Unfortunately, since we went to blastocysts, we rarely do. We still make a lot of twins. In fact, going to blastocysts, we started making more twins, because going to blast and selecting 2 embryos for transfer with better embryos being selected by the culture system, we were making more twins, and even that's a problem, and we'll talk about that through this discussion. There's controversy about extended culture, and the group in the University of Pennsylvania looked at all of the SART data that's published by the CDC, and they combed through that data and found that there appeared to be problems with babies born from extended culture. They had a higher risk of preterm labor and smaller size, and so it came into question whether blastocyst was going to be a problem solver or a problem creator. The problem with this study is that it didn't account for the vanishing twin syndrome, which does increase the risk of preterm delivery. And other centers, including our own, published a similar analysis of our data and didn't show these effects. But the suggestion was that doing an embryo transfer in the stimulated environment put the blastocyst culture patients at more risk for preterm labor, and that is a problem. And we'll see how that's addressed as I continue the talk. It turns out ovarian stimulation alone is a problem. That when you look at the impact of ovarian stimulation on the endometrial impact and then the placenta that forms, that there is this evidence that's evolving in many studies that shows that babies are born smaller and earlier when embryos are transferred in the stimulated environment, and yet when you look at frozen embryo transfers, you don't see that impact, nor do you see it in the donor egg population. So there is this thesis that stimulation affects the endometrium, and the idea of freezing all the embryos and transferring only in a thaw cycle is evolving, and now there are programs that exclusively transfer frozen embryos, frozen thawed embryos, and I think that's more of a trend. You know, there's still an issue with the patient population, that infertility patients have more risk, and some of the risk just reflects the patient population, but also stimulation, again, in another study, this meta-analysis, has been shown to impact the perinatal outcomes. And again, one more paper that suggests that doing fresh embryo transfer may be suboptimal, and that ovarian stimulation causes problems despite the fact that it gives us more embryos to select from to find the one good one that makes the baby. If you transfer embryos in that environment, there are risks that are incurred because of that, and these are avoidable by freezing embryos. And indeed, this meta-analysis looked at frozen embryo transfer cycles and compared them to fresh IVF cycles, and now multiple studies, as well as this meta-analysis, which evaluated many of those studies, has shown the superiority of frozen embryo transfer in the outcome, the obstetrical outcome. Babies are bigger and born closer to term, there's less prematurity, and so the concept of separating the stimulation from the transfer has now evolved to the point where recently the American Society of Reproductive Medicine hosted a webinar journal club where we debated the practice of no longer doing fresh transfer and only doing frozen embryo transfer, a view that I am strongly in support of, and many of us are, although I would add there's more to that story than just doing a frozen embryo transfer, and that's the rest of this talk will address those issues as well. If you're going to freeze an embryo, why not know what its chromosomal status is before you transfer it? And that's where we're headed with this talk, to talk about that. But I want to talk more about the endometrial impact. Bruce Shapiro and his group did a very wonderful study that showed the impact of stimulation on endometrial receptivity. He did a randomized controlled trial of patients, similar patients, randomized to either fresh transfer, standard of care IVF, which is standard of care currently in the United States, versus freezing all the embryos at the pronuclear phase, and then doing a later thaw cycle where he thaws the pronuclear embryos and selects embryos at blastocyst stage for transfer. And he showed that an improvement in endometrial receptivity on the order of somewhere in the 60% range, suggesting that a fresh embryo transfer is compromising care, and that frozen embryos, which used to be a problem, our success rates with that were not as good. Now with vitrification and new technology, the impact of freezing an embryo is not measurable. It doesn't have a negative impact on embryos, and the obstetrical outcomes being better. And now with the fact that this study shows that you can improve the ability of the embryo to implant and make a pregnancy, it really looks like frozen embryo transfer is the way to go. And fresh embryo transfer is no longer going to be the standard of care. And there's other benefits of that too. Bruce's group showed, in addition, a much lower ectopic pregnancy rate. And you know, as practitioners, we want what's best for patients. And yes, we're willing to take risks for gains. And any person who risks getting pregnant risks having a miscarriage or risks having an ectopic pregnancy. The ectopic pregnancy risk in the population at large is 2%. And in IVF, with a fresh embryo transfer, it's 2%. But with a frozen embryo transfer, it's way less than 1%, less than half percent. And you know, anyone who thinks going through an IVF cycle and getting an ectopic pregnancy is a good outcome obviously isn't thinking. And now we have technology that allows us to avoid that. Why wouldn't we reduce our risk for our patients and improve outcomes? So as we got better at blastocysts, we could see that certain groups of patients did better. And patients who got to day 5 and had a number of blastocysts, even up to age 40, that the embryos reached a certain stage in the Gardner criteria, stage 3 to 4 blasts, AA, BBs, if they had 3 or more of those embryos, we found that single embryo transfer gave us very high success rates, very low multiple rates, and barely compromised the pregnancy rate. So we didn't have to be transferring 2 embryos in that group and making lots of twins in the process to assure a good pregnancy rate. Unfortunately, this is not the majority of our patients who fall in this category. Not many patients have that many supernumerary blastocysts on day 5 because many of the patients we deal with are poor prognosis patients, and they're a different group. But certainly this group of patients, putting back a single embryo transfer gives very high success rates and lower miscarriage rates, but these aren't the majority of patients. And so we need to address that, and that's where preimplantation genetic screening, preimplantation genetic diagnosis comes into play. And this next paper by Mastenbrook, which was published in New England Journal of Medicine, a very well-designed study, which unfortunately had so many problems with the technical aspects of it, that the conclusions that it made, in my mind, are in question and many others' minds, although this is a controversy and one of heated debate. But this study was done at a time when day 3 biopsy was being done, which I'll show you later is a problem in and of itself. And they were using FISH technology to diagnose embryos and not testing all of the chromosomes, another problem. And in addition, in this study, 20% of the embryos remain undiagnosed, and they were transferring undiagnosed embryos and making conclusions about the success of preimplantation genetic screening. And of course, they concluded that it was more harm than good, and in their system and in their circumstance, and with the baseline pregnancy rate that they reported and the lower implantation rates in this study, that was what one would expect to see. But if one did a sub-analysis of the data in this study, and I have, and wrote a rebuttal to this with Jacques Cohen that was published, the actual embryos that were diagnosed as euploid, if you looked at them exclusively, they did actually show a statistically significant improvement in implantation rate in those embryos. And I think this study drew the wrong conclusion and was severely lacking. And now it's really not even relevant, because the way that this study was done is not the way that we do preimplantation genetic screening. But it really caused a lot of heartache in our field and discouraged a lot of people from doing preimplantation genetic screening. It's unfortunate. But now, as you'll see in the papers I'm about to present, there's much more reassuring data about this technology. And so by doing trophectoderm biopsy, which I'm showing in this video, and a real live video of an embryo biopsy, where we take 5 to 10 cells from the trophectoderm of the embryo and use the laser to pluck off those cells, and then take that embryo and put it in the freezer while we take those cells and ship them off to a reference lab to run a 24 chromosome analysis. And our particular group uses their RACE-CGH platform. There are many platforms, and the newest platform, next generation sequencing, has a lot of promise as being another technology that we'll use. But there's PCR-based technologies, there's SNP arrays, there's lots of ways to analyze and determine whether this embryo that's being biopsied is chromosomally normal or not, whether it has Down syndrome or not. And by using this type of selection, we can be assured that we're transferring an embryo that has a chance of success. Because if you think about what the goal of IVF is, our goal is to transfer a single euploid embryo and get a single euploid baby. And if you start by transferring a euploid embryo, you got a much better chance of getting there than just transferring an unscreened embryo, which has a very high chance of being aneuploid. And there have been a number of investigators now looking at this technology. This is Schoolcraft's group in conjunction with the Reprogenetics group, publishing an initial series showing that if you did blastocyst biopsy and transferred chromosomally screened embryos that are euploid with respect to the 24 chromosome analysis that was done, that there were improved implantation rates, lower miscarriage rates, and suggesting that this technology was going to offer our patients a much improved platform to get a singleton pregnancy and a better outcome. And this is one of many studies. Around the same time, we were working on the same project, and we wrote a paper in 2010 that eventually got published in 2013 called Single Thawed Euploid Embryo Transfer, which allows us to transfer a single chromosomally normal embryo. And it didn't matter the age of the patient. We could achieve implantation rates equivalent to egg donation and superior to in vitro fertilization with unscreened embryos. In addition, we had miscarriage rates that were superior to both egg donation and IVF, and suggested that this technology could solve the problems that I talked about earlier in the slides, that multiple gestation and all of its subsequent problems that it results in, preterm labor, that this technology could offer us solutions to the problems and make IVF safer and more effective. And to be quite honest, when you include all the costs, including the cost of caring for multiple pregnancies, the miscarriages that we avoid, the actual cost of doing this technology will more than pay for itself, not to mention the emotional cost, which never has a dollar value but should. The pregnancies that get terminated for Down syndrome that won't be because of screening. We need to factor in these things when making clinical decisions with our patients. So there's a lot to be said about this. There'll be a lot of debate about it, but the data is there. Another study Bill Schoolcraft did with Richard Scott's group and showed similar finding that if you screen embryos and put back euploid embryos, you're going to get better outcomes. You're going to get singleton pregnancies if you put one embryo back, and you get lower miscarriage rates and higher pregnancy rates. Richard Scott's group at RMA really put a lot of science into this and did some very fine studies that were randomized and controlled. And they, in this study, they did a prospective blinded non-selection study to look at the efficacy of pre-implantation genetic screening at predicting implantation. And in this study, what they did was they biopsied embryos and didn't act on the results. They actually didn't run the results till afterwards. They chose embryos in the traditional IVF way and looked at the pregnancy outcomes afterward. And by fingerprinting and knowing what they transferred, they could determine that how predictive an aneuploid screen would be at predicting whether an embryo implanted. And 96% of the embryos that were aneuploid did not implant or make a sustained implantation, as they describe in this paper. And that when an embryo was selected as euploid, that a large percentage of those embryos implanted and had good outcomes. And he actually showed for the first time in a very scientific way that this technology has legs and works. And it's a very elegant study, and congratulations to his group and to the patients who were willing to let him do this study because they took medical risks, in retrospect, not much of medical risk, but and allowed this data to be collected, and that's really helped our field. But it really validated that pre-implantation genetic screening works. The group of Yang actually did a very elegant study where they took young, healthy patients and randomized them to blastocyst biopsy, trophectoderm biopsy, day 6 transfer of a single euploid embryo versus day 6 transfer of the best untested embryo, and randomized patients and showed a superior implantation rate, superior pregnancy rate, and lower miscarriage rate in the group of patients that you expected this least to help, the young patients. You wouldn't expect that this technology would help that group of patients, but indeed it does, and the reason it does is even in young patients, a large percentage of embryos that look morphologically normal and healthy are not, and we're transferring those every day in IVF labs if we're just using morphologic criteria to select embryos. And that is the problem with our technology, and now we have new technology that allows us to avoid that problem. And this is one of many studies that now documents in a randomized controlled way the superiority of doing pre-implantation genetic screening. And so Richard Scott did another trial where they did blastocyst biopsy with comprehensive chromosome screening and fresh embryo transfer, and did a randomized controlled trial to standard of care IVF, and again demonstrated the superiority of pre-implantation genetic screening. And I'll keep showing you paper after paper of this technology being the technology that does this for our patients, despite the one paper published by Massenbrook which disputes that, although I don't think that paper is relevant considering we're no longer doing day 3 transfer or day 3 biopsy and or transfer, that we're screening for all chromosomes, not just 9 or 12 chromosomes. We're actually doing a true euploidy check. And here's one retrospective review which shows the single embryo transfer of chromosomally screened embryos results in better ongoing pregnancy rates and lower miscarriage rates, and that's what we want for our patients. Yet another study. And here's in vitro fertilization with single euploid blastocyst transfer, a randomized controlled trial of the study that we presented as a retrospective study. And what they showed in this study that if you transferred a single euploid embryo and compared it to standard of care to embryo transfer of unscreened embryos in IVF, that there were better implantation rates, better pregnancy rates, and lower miscarriage rates. Again, documenting that this treatment works. And how many randomized controlled trials will it take us to actually believe it? Because there's still debate among our practitioners that this technology is harming patients, despite the fact that there's no data to support those contentions. I think it's not something that a lab should just start doing one day. There's a learning curve. We had a 20-year learning curve perfecting these techniques, and every lab needs that, although you don't need to have a 20-year learning curve. The technology is there, and most embryologists have been exposed to all the techniques, and there just needs to be progression in the lab to segue into this technology. And I think it's going to be the way we treat all patients in IVF, although there are a lot of critics who don't agree with my statement. Richard Scott's group did another interesting study, because a lot of us are freezing eggs now for fertility preservation, and the concern is that if you freeze an egg, are you going to affect its ploidy? Are you going to affect the aneuploidy rate of embryos? And Richard did a study looking at frozen thawed eggs and showed that vitrification did not change the rate of aneuploidy in embryos derived from eggs that had been frozen versus ones that hadn't. And that's a very reassuring thing for those of us freezing eggs for fertility preservation, for both cancer patients and for women who are electively delaying childbearing, knowing that in the future their fertility is going to decline, and they freeze their eggs to protect their future fertility so they can be their own egg donor with their own frozen eggs. Now, we showed in a very elegant way that blastocyst culture does select for euploidy. And while we wrote this paper in 2010, it took us several years to get it published because it wasn't as a randomized controlled trial, but it was similar patients at a time when we were segueing from day 3 embryo biopsy to day 5 embryo biopsy, but looking at similar patients over those two time periods, a period of 4 years where we went from strictly day 3 biopsy to strictly trophectoderm biopsy, and then looked at the percentage of embryos that were aneuploid. What we showed in this paper was that twice as many embryos were likely to be aneuploid on day 3 as on day 5, which proved the thesis, and I showed you earlier in a paper just looking at miscarriages and studying the chromosomal abnormality rates. We showed that day 3 embryo transfer were more likely to be chromosomally abnormal, and this actually proves the thesis that embryo culture selects for euploidy, that it's not a perfect selection by any means. It doesn't substitute for pre-implantation genetic screening. But the idea, if you go to blastocysts and then you only test blastocysts, you test fewer embryos, it costs less to do so, you freeze embryos, and Richard Scott's group has very elegantly demonstrated that the superiority of blastocyst biopsy over day 3 biopsy. In fact, his study showed that day 3 biopsy does harm some embryos and lower the implantation rates. And so that is a problem. It's no longer a problem now. Biopsied blastocysts, you don't change their implantation potential by biopsying them. And so now we can do this technique in a safe, efficient way and get the information that we need to be assuring our patients that we're putting back a chromosomally normal embryo. We also use this technology to look at a specific group of patients. The group that we were using mainly PGS4, and that was the recurrent miscarriage group, because in the early part of this century, we showed that recurrent miscarriage was a problem that could be improved, the outcomes could be improved by doing pre-implantation genetic screening, even using day 3 biopsy, even using chromosome screens that didn't check all the chromosomes. But now with array CGH, we looked in a multi-center way at patients who had recurrent miscarriage who historically would then, on their next pregnancy, have a 35% miscarriage rate. And by selecting only euploid embryos and transferring them in these patients, we took their 35% miscarriage rate down to less than 10% and showed for the first time that most idiopathic recurrent miscarriage was caused by aneuploidy. Not a surprise, but never been demonstrated, and this study demonstrated that. We also showed in a multi-center way that the age effect is really about aneuploidy, that when you screened embryos and put back only euploid embryos and looked at implantation rates, that age impact of implantation went away when you put back chromosomally normal embryos. If you look at the blue bars on this slide, it looks at the age effect of implantation on unscreened embryos. It's basically the SART data, which you can take off the web, and it says what the implantation rate is in the average of all the United States clinics, ours included, when you transfer embryos that are unscreened, and it shows the age effect of implantation. The purple bars actually show when we put back a single thawed euploid embryo, and the implantation rate is age independent because the age effect of fertility is aneuploidy, and when you screen out aneuploid embryos, the age effect goes away. And that's really important, and that also supports the thesis for doing this, because most of our patients are older, and most of our patients we're putting back aneuploid embryos if we're not screening, and that is not the way to practice medicine in today's technology, with the technology that we have available to us. And there's always been this debate about stimulation. Does stimulation make worse embryos? And there are practitioners out there who are saying to their patients, no, we need to do minimal stimulation, little lower stimulation to get better eggs and better embryos. But there's no credible evidence that that's a true statement. Now, it may affect the endometrium, and if you're doing fresh transfers, stimulation clearly does have an impact. But if you're doing frozen embryo transfer, there's no evidence that stimulation impacts the quality of the embryo that you get in any measurable way. And in fact, this study, elegant study, multi-center study, looked at this question. And it's a busy slide. It shows the thesis. It looks at different ages. And let's just, for simplicity, look at the 40 to 42-year-old patients. And look at the patients who had a lot of stimulation and got a lot of embryos, more than 10. Compare them to the patients who only had a few embryos, 1 to 3, and everywhere in between. And if you look in that column and you see the bold numbers, those are the cycles where at least one embryo was chromosomally normal. And clearly, the more embryos you had, the better the chance of having at least one chromosomally normal embryo. But the percentages in the small print, and you can see 34%, 31%, 27%, 41%. That's the percent of chromosomally normal embryos in the cohort. And what it shows is that despite vigorous stimulation or less vigorous stimulation, the percent of embryos that were normal did not change. And thus, the thesis that stimulation makes worse eggs and worse embryos is not true. And this data proves it. So, the strategy becomes more of stimulate more aggressively, get more embryos, test them, freeze them, and then put back one chromosomally tested embryo, and you can get better pregnancy rates in the older patients and make IVF more efficient and do fewer cycles to get those babies, and in many ways reduce the cost, not raise it. So if you look at our experience and you look at the average percent of chromosomally normal embryos after biopsy and look at it by age, it's remarkably similar to the age-related decline in pregnancy rate that you see with unscreened embryos, because it explains the age-related decline in pregnancy rate. In the older patients, we're putting back beautiful embryos that aren't normal, that aren't healthy, that won't make babies. And unless we screen them out, we will fail, and we will make miscarriages. And we will have patients call us with their 16 weeks amnio results and tell us that they had to terminate their affected pregnancy with Down syndrome or Turner syndrome because we didn't screen it out. What a terrible outcome from IVF, to get to 16 weeks and then have to terminate the pregnancy. The trauma is underestimated by us, and while we describe it as an act of nature, and it is, we have the ability now to avoid that circumstance. And that is the absolute worst outcome of IVF, and now we can reduce the chance of that happening very dramatically. The next slide shows the percent of cycles, if we don't screen, that we're putting back only abnormal embryos. Because it's our experience where we tested all the embryos in a cycle at different ages, and what you can see is the women over the age of 42, that 75% of those cycles we're putting back embryos that don't give them a chance, and they're spending 9 to 11 more days injecting progesterone, waiting for their pregnancy test, wondering why their cycle failed, wondering what they did wrong, wondering what they ate or drank or smoked or did that made their cycle fail, wishing they had done one more acupuncture appointment, or all the things that they do when they didn't have a chance to begin with, and we didn't give it to them because we didn't screen their embryo. And we can do better. The data is there, the technology is there, the randomized controlled trials are there to say that it's the right thing to do, and we can do that now, and it's an option. So, and here's an example. Here's a group of our patients that chose doing single thawed euploid embryo transfer. That's the top group. And these are similar aged patients, cycled at a similar time. And this group of patients chose this technology over traditional IVF. It's at a time when this new technology is evolving. And they chose it because many of them had miscarriages that were chromosomally abnormal. Many of them had failed multiple cycles at other centers than ours, and now decided that they would do the chromosome testing to see if they had normal embryos to transfer. So they weren't better prognosis patients, as my critics have said. And we compared them to similar patients, similar age, similar mean FSH values, similar mean AMH values, number of eggs, number of embryos, except this group of patients had fewer cycles under their belt, fewer miscarriages, and they weren't a worse prognosis group of patients. They were a better prognosis group of patients. And when you compared traditional IVF, which is on the bottom line, the fresh transfer, where we're putting back almost all the embryos they make, 2.6 was average. It would have been higher. Some of the patients only had one. And that group of patients, we had a 19% ongoing pregnancy rate, which is what you see for unscreened embryos in 41 mean age patients, and a 43% miscarriage rate. And if you look in that graph there, there's that number 4 represents 4 terminated pregnancies, the worst outcome you can get from IVF. And then also the number of twins that were created, 23% twin rate because we're putting back too many embryos. And you compare that to a single thawed euploid embryo transfer where we put back a mean of 1.2 embryos because 2 patients demanded 2 embryos instead of 1. But we had a 55% baby rate, which is donor egg baby rates in a group of patients who have no business getting donor egg baby rates. But if you're putting back euploid embryos, you can achieve that. And their miscarriage rate, instead of being 43%, was 13%. So for every 100 pregnancy scans I was doing, there were 30 fewer patients I had to give the bad news to and then set up their D&C and do their D&C and end their pregnancy that was not healthy. And there were no patients who had to terminate a pregnancy for Down syndrome because we screened out most of those embryos, although with not 100% accuracy because nothing's 100% in real life. But very accurate and very good outcomes so far. And the error rates we're seeing are less than 0.25% and making very few twins. This data shows that, especially in this group of patients, we can do better. We can offer them better outcomes, singleton pregnancies, lower miscarriage rates, fewer terminated pregnancies, and that's kind of what we're supposed to be doing. That's why we're here. We want to give our patients the best chance, and the technology is there to do it. And we choose to do it, and now patients are choosing to do it. And this is a busy slide, but I just want to show you one thing. At the time we're doing this single thawed euploid embryo transfer, the big numbers at the bottom represent the number of terminated pregnancies in the PGS group. And yes, the N is different. It's about 340 cycles compared to about 2,400 cycles in the IVF group and the frozen embryo transfer group of untested, non-biopsied embryos. There were 14 terminated pregnancies. That's what we avoid by doing this technology. And yes, there's more cycles, but there were no terminated pregnancies in the group where we screened the embryos. That's a good thing. And those 14 patients who had to lose their pregnancies at a very late stage and be traumatized, that's standard of care IVF. That no longer has to be standard of care. And so, I'd like to conclude my talk with the literature supports doing pre-implantation genetic screening as I've described. The safety of the technique exists, that the safety of biopsy has been demonstrated, the accuracy of the different platforms to screen for aneuploidy is there, the lower miscarriage rates, the better implantation rates, the better outcomes has been shown, and now it just becomes a cost-benefit analysis, I guess, as a final way to decide if that's the way we want to go with it, although we need to value things properly. Terminated pregnancies, what's the cost? What's the value? Ask those 14 patients who had to terminate their pregnancies what the value would be. I'm sure they would be happy to pay for pre-implantation genetic screening to avoid that outcome. But if you just think about it from a logical perspective, and I know in medicine logic isn't always logical, but if the outcome is a single euploid baby, you have a much better chance of getting there transferring a single euploid embryo. And I showed you in this talk how many embryos we transfer that are not euploid. And that's not what we should be doing, and we have the ability to not transfer aneuploid embryos. The options are there. It's our choice. It's our patient's choice. Transferring aneuploid embryos creates a lot of the problems that we have with our technology, and now historically we don't need to do that anymore. The literature is highly supportive of frozen embryo transfer. It dramatically improves obstetrical outcomes. The idea of doing fresh transfer, I think, The time has come. The data is there to support it. I showed it to you. There's more data than I showed in this talk. And you know, the idea of freezing an embryo, now with the data saying it's safe to test, it's safe to do the blastocyst biopsy. If you're going to freeze the embryo, now you have the luxury of time of determining if it's chromosomally normal or not. It doesn't matter the age. Now you can find out and transfer a single euploid embryo, much better outcomes, and it makes sense to do that. And the data is there to support it. It's not the wrong thing to do, and you can't use the Mastenbrook trial that was published in New England Journal as the reason why we shouldn't be doing this. It's not relevant to the way we practice now. And we know that most miscarriages are caused by aneuploid embryos, so if we screen out those aneuploid embryos, avoiding those miscarriages from a cost perspective is huge, from an outcome perspective is huge, and from a time perspective is huge, and we can do that now. And so I truly believe single thawed euploid embryo transfer offers a way of performing single embryo transfer that maximizes outcome, assures singleton pregnancies in most cases, reduces bad outcomes, and improves the way we treat our patients. And that's the way many of us are practicing. I see a paradigm shift. It's been talked about. There was a recent American Society of Reproductive Medicine webinar debate that I was part of with Richard Scott and others, that we talked about this, and it's pretty clear that this is the future of IVF, and we're embracing it. Thank you for your attention.